Alright, so now cerebrovascular disease, which is when you get reduced blood flow to the brain and you present with neurological deficits. This is because the neurons really need serum glucose for energy, and blood delivers oxygen. Oxygen you break down. There's glucose in the blood first of all, and you gotta break down. You need oxygen as well. So without the energy, your neurons will die within 3 to 5 minutes of ischemia. So very quick. You don't have very much time if you have ischemia to a certain area of the brain before it dies. And remember that neurons do not divide. These are permanent cells, and once they're dead, they're gone forever. They do not come back. You do not replenish your neuron supply. So this is a big deal. Now there are two big groups of cerebral vascular disease. The first one is global cerebral ischemia, leading to global neurological deficits. Remember we talked about the difference between that and focal neurological deficits, which is what a stroke will present with, because this is a regional ischemia. Okay? So let's talk about global cerebral ischemia first. This one's really quick. It's a quick talk. There's multiple causes of this. You can have reduced blood flow. Maybe you're bleeding out or something, or just anything that can cause reduced blood flow to the brain. You can have low oxygen in the blood. If you're anemic, perhaps, you have low hemoglobin, low red blood cells to carry oxygen into your brain. So even though your blood flow is good, there's not much oxygen in that blood. It's low quality blood, and so your brain still gets, your neurons are still starving for oxygen and not enough energy. Finally, just even severe hypoglycemia can do it, which is why you want to be careful about hypoglycemia. Because even though there's blood going to the brain, there's no glucose in there, and your brain needs glucose to make energy. So all of these are possible. Reduced blood flow, low oxygen, or low glucose can all cause reduced energy for neurons. And this can present in several ways depending on the severity of your ischemia. Mild ischemia leads to just transient confusion. Your cells don't actually die. They're just like gasping for air, but they're not dead yet. So they're a little confused for a little bit, and then you once you restore that blood flow, the confusion resolves. If it's moderate blood flow, moderate ischemia globally, remember that the first parts of the brain that are going to get hit are at the periphery, in the watershed areas. These guys are out in the podunks. They have the poorest blood supply, and they're going to get hit first. There's also a couple more vulnerable cells in the brain that you want to note. Pyramidal cells of the cerebral cortex, also pyramidal neurons of the hippocampus, and the Purkinje layer of the cerebellum. And remember, these are all in the newer part of the brain. These rely on oxygen more. They're very vulnerable, and these can die quickly. These are the first ones to die in ischemia. Finally, if you have severe global ischemia, you get diffuse brain cell death and a vegetative state. Your brain basically doesn't really work. The only thing is it's enough to keep you alive. Remember, those deep brainstem structures are a lot more sturdy. So you're still just your vegetable. Your personality doesn't work. No memory, no speech, no nothing. You can't move your body. You get no sensation. But your respiratory and heart functions are still there. Alright, now let's go on to stroke. Remember that there's two groups. There's the global, and then the stroke, which is regional ischemia. So stroke can be divided into two big categories as well, so we can further subdivide things. The first one is an ischemic stroke. That's the majority of strokes, 85%, and this is due to acute blockage of our vessels. You block vessels, you block blood flow to a specific area of the brain, you get ischemia of the neurons, and then you're going to get liquefactive necrosis. I'll talk more about that in detail later, but there's liquefactive necrosis. There's a couple types of a couple causes of ischemic stroke. You can have a thrombotic stroke, so it's basically a heart attack of the brain to me. You have a plaque on the blood vessel, and then you get that thrombosis event, and it blocks up that blood vessel, and everything downstream from that vessel dies. The next one is an embolic stroke. You get an embolus, which is a blood clot from somewhere else in your body. Could be, I think most commonly, atrial fibrillation. You get a blood clot in the heart that shoots up to your brain, and then that gets clogged up in a blood vessel, and then everything downstream does not get blood anymore, and it dies. And finally, there's a lacunar stroke. We're going to talk about that later. This is just a brief introduction. Next is a hemorrhagic stroke, okay? This is, remember, the minority of strokes. This is blood from a ruptured brain aneurysm or a blood vessel that spills into or around the brain. This causes swelling and pressure on neurons, and damages the cells, and then they die. And so that's how you can get focal deficits from a hemorrhagic stroke. And there's two main types. There's the intracerebral hemorrhage, so inside the brain itself, in the parenchyma. And there's a subarachnoid hemorrhage. Remember that arachnoid is part of your meninges, which is the wrapper for the brain. So there's multiple layers of the wrapper. So subarachnoid is the second layer. So there's going to be blood basically between two layers of your brain, but not inside the actual brain. Not touching the brain. The blood is not touching the brain at all. In intracerebral hemorrhage, it's touching the brain. It's bathing the brain and causing pressure. Alright, so let's go focus on ischemic stroke now. I've already mentioned the pathophysiology. We talked about thrombotic rate. It's similar to cardiovascular disease. Clot forms over the atherosclerotic plaque, and this is usually at bifurcations of the circle of Willis. So that's where the atherosclerotic plaques love to form, and that's where the clot also forms as well. Remember, the embolus is from other parts of the body that obstruct your vessel. So it usually involves the middle cerebral artery. Don't ask me why, I don't know. And finally, lacunar strokes. And this is due to chronic hypertension, and it involves the lenticulostriate small vessels. I'm going to draw that out for you. So these are big vessels here, okay? This is your MCA that's going to come. MCA is going to come this way. Remember, it does the lateral part of the brain. So this is the MCA. And MCA has a lot of branches. So it's going to go, these are all blood vessel branches that perfuse the deep parts of the brain, okay? This is the deep part of the brain. And these branches are the lenticulostriate vessels. These are small vessels branching off of the middle cerebral artery, perfusing the deep parts of the brain. So if you can get chronic hypertension, it's going to cause something called lipohyalinosis. To me, it's almost basically the same as that, the cardiovascular disease. It just blocks up the lumen. So this is the lumen of the vessel here. You get lipohyalinosis, and it gets clogged up due to hypertension. Eventually it gets clogged enough that you get occlusion of the blood vessels and necrosis of this deep brain structures. Let's see, I'm showing it on the right. This usually presents with either pure motor symptoms or pure sensory deficits. So this is the way you can tell when it's a lacunar stroke, because it's either only motor or only sensory, because there's an involvement of the internal capsule here. This is where our motor tracts pass through, or pure sensory deficits in the thalamus, where the thalamus is our sensory relay center. So when you take that out, you're going to have pure sensory deficits. Okay. The treatment for this, well, first of all, this presents with focal neurological deficits from the specific areas of the brain. And we'll talk about specific deficits because your deficit will depend on which part of the brain died. And treatment is, you can give TPA. This is a clot buster. It's basically prevents clot formation if there is no risk of hemorrhage. So you don't want to do it if the patient has a risk of hemorrhage, because if you're bleeding out, you actually want clots. Clots are your friend in that case. So if you don't have a clot, you give them a clot buster, they're just going to keep bleeding, and they're going to be in trouble. So TPA is your first option, and then you give them aspirin or clopidogrel to prevent risk of recurrence. So it prevents clot formation, basically. And you also want to treat underlying conditions or risk factors. So maybe AFib was causing the embolic stroke. Maybe you had severe hypertension, severe diabetes that's putting you at risk for this. So you want to treat all these underlying causes of this ischemic stroke. Next is a TIA, which is basically, to me, it's a transient mini stroke. These are both, keyword transient and mini. So it's you're gonna have similar symptoms, and it's also due to focal ischemia. So this is the same as stroke, but the big difference here is that there is no evidence of infarction on your MRI. Okay, and your symptoms resolve within 24 hours. Hence the word transient. There's no evidence of any stroke on imaging, and your symptoms resolve. However, these patients are at increased risk of stroke in the future. They have pretty much the same risk factors. It's just a minor thing. So basically, everything that can cause a stroke they have, theirs didn't go as big, so their brain cells can recover function and don't look like they died on imaging. So now we talked about ischemic stroke, we'll go on to the hemorrhagic strokes. We mentioned a little bit about pathophysiology. If you remember, it's blood from ruptured brain aneurysms or blood vessels spill into or around the brain, and this can cause swelling and pressure, leading to damaged blood cells. The two main types we talked about, do you remember the two main types? Remember, we can divide this into either intracerebral hemorrhage or subarachnoid hemorrhage. Intracerebral first, there are multiple causes of this. This is almost a subtype for me, but it's not. There's multiple causes of blood that can be bathing around your brain, causing damage. The first one is hypertension leading to a Charcot-Bouchard aneurysm of your small vessels. Again, this is affecting the lenticulostriate vessels. And then you can have these aneurysms, which are a weakening of the wall. So imagine this is your regular blood vessel, and you have all this high pressure, and if a weakened wall, it's going to push out, and that's an aneurysm. Okay, this is weak. So you have a nice thick wall here, and then it's weak. Okay, and this can rupture, and if it does rupture, guess what? Now you got a big fat hole, and you got all this blood gushing out of here into your brain. Okay, so that's not good. That's a Charcot-Bouchard aneurysm. The next one is cerebral amyloid angiography. And the big thing to note here is that you see this in old patients. Remember, amyloid is, what disease did we see amyloid in the brain? Remember, that was Alzheimer's disease, again, old patients. So amyloid it just affects the blood vessels as well as the brain, and you can cause bleeding. Next is the ruptured arteriovenous malformation. That's basically when you have abnormal connection between your arteries and your veins. Very simple, arteriovenous malformation. And these can rupture. These can rupture, and you usually see this in young patients. So intracerebral hemorrhage in young patients is ruptured AVM or arteriovenous malformation. And if it's an old person, it's probably a cerebral amyloid angiography. The next, remember, so there's the two main types. The second main type here is subarachnoid hemorrhage. This is also due to aneurysms, but this is the Berry aneurysm, and it's usually located in the circle of Willis. So in the circle of Willis, you get a subarachnoid hemorrhage. In the lenticulostriate vessels, you get Charcot-Bouchard aneurysms. And the ways these present a little bit differently. The intracerebral hemorrhage presents similarly to ischemic stroke, and then you're going to get focal neurological deficits in the region of the brain that's bleeding out. Remember, it's not the whole brain that's bleeding. It's going to be a specific area, specific blood vessels that are going to be bleeding. Subarachnoid hemorrhage is more just widespread because the blood will perfuse throughout your subarachnoid layer, which is the wrapper around the brain. Imagine if you put some liquid around two wrappers, the liquid's going to spread out all through that wrapper. So what you're going to get is you're going to get a sudden onset worst headache of life. So the sudden onset is due to it's rupture. Remember, it's a rupture of the Berry aneurysm. So that rupture, that instant that rupture happens, you get a sudden onset worst headache. It's going to be a really bad headache, and there's also going to be neck stiffness. And the reason for that is because your meninges go all the way down to your neck. So if you have blood, you're going to get irritation of the meninges, and then irritation causes the stiffness. And you know what this sounds like? This sounds similar to meningitis. It's the same idea. Meningitis also has irritation of the meninges, and so you get headache and you get neck stiffness. But the difference here is that this is a sudden onset worst headache of life. So that's the way you can remember it, differentiate it. So the treatment for this is not too important, but I just want to show you the difference here is that you can't do much here medically. This is a surgical issue. You need neurosurgery to come in here, and maybe they may need to stop the bleeding. They may need to remove clots or reduce intracranial pressure. Okay, so let's compare compare and contrast aneurysms now. We talked about the saccular aneurysms, which we also called Barry aneurysms, and then we also talked about Charcot-Bouchard aneurysms. Remember, these are abnormal dilations of the arterial wall due to weakening of the arterial wall. And the risk factors here are varying. The Barry aneurysms you have to watch out for is ADPKD is autosomal dominant polycystic kidney disease. It's and the name says polycystic kidney disease, but really this is a disease of cysts all over the body. So you can have cysts in your liver, blah blah blah, and then you can also have in the brain. And this is so cysts in the brain to me are basically aneurysms. So that's why this is a risk factor for getting Barry aneurysms. Ehlers-Danlos syndrome, remember, we said was it's a connective tissue disease. You have weak connective tissue, and we said this is due to weakening of the arterial wall. That's how you get aneurysms. So that can make you understand why this is a risk factor for having Barry aneurysms. Next is age, hypertension, smoking. These can all lead to weakening of your arterial wall, and then that's when it's going to get the pressure pushes out, makes it balloon out. That's how you get an aneurysm. Thing to note here in Charcot-Bouchard aneurysm is that the main thing here is hypertension. Hypertension causes Charcot-Bouchard aneurysms, but do note that it can cause both. Now, do you remember what is the location of these aneurysms? And actually wrote it incorrectly in this presentation, so I'm gonna have to. I will correct this in the downloadable slides, but the Barry aneurysms occur at the circle of Willis, most commonly at bifurcations, and Charcot-Bouchard aneurysms are the ones that occur at lenticular-striate vessels. So ignore all this and just listen to what I said. Okay, Charcot-Bouchard at the lenticular-striate vessels, saccular aneurysms at the circle of Willis, most commonly at bifurcations. Now, what is the result of this rupture? We already talked about this. When the Barry aneurysm ruptures, what do you get? You get subarachnoid hemorrhage. When the Charcot-Bouchard aneurysm ruptures, what do you get? You get intracerebral hemorrhage. Remember, this is usually a localized bleed. How does subarachnoid hemorrhage present? What were the symptoms that we talked about? Do you remember? Remember, it was a sudden onset worst headache of life, and you get neck stiffness. And then for the Charcot-Bouchard intracerebral hemorrhage, remember that was usually progressive neurological deficits, focal, because it's just a focal part of the brain. Okay? And I just want to illustrate to you that a subarachnoid hemorrhage, remember we talked about first of all, this is how it looks like on the MRI. This is the gray stuff, the gray whitish stuff, especially the arrow showing you, is all subarachnoid blood. It's not in the brain, it's in this arachnoid layer. And this is the starfish sign, and it looks kind of like a star, as you can see. I made it look worse, but that's the starfish sign, okay? Plain little star. The intracerebral hemorrhage here, you can see it's a focal. This is probably Charcot-Bouchard because it's in the deep layers where lenticular-striate vessels are bleeding out. And again, I want to emphasize that your subarachnoid hemorrhage is not in the brain itself. It's in there's a little wrapper of pia matter around the brain, and the subarachnoid hemorrhage is going to be around that pia matter. It's going to be above the pia mater, between the pia mater and the arachnoid layer, and it's just going to be right here, just surrounding the brain, but not in it. Okay. So that's the red. Then maybe I'm going to draw the pia mater here. That is our other layer surrounding the brain. Okay. And then we can draw the arachnoid layer as well. So arachnoid layer, pia mater, and then blood in between those two. Got our blood here. This is the subarachnoid hemorrhage. Okay, additional information from the subarachnoid hemorrhage. The way you diagnose it is the gold standard is a spinal tap. You can get imaging that can show you that starfish sign that we mentioned, starfish sign right here. But sometimes imaging doesn't work, so you got to do a spinal tap, look in the cerebral spinal fluid, and what you're going to see is xanthochromia. Okay, what this is yellow spinal fluid, and that's due to the breakdown of blood. Blood becomes bilirubin, if you remember that stuff, and it looks a little yellow. So if you get yellow spinal fluid, it tells you subarachnoid hemorrhage, boom, done. The other thing to worry about is you can get vasospasm after your hemorrhage. Vasospasms it squeezes in the brain. This happens a lot after subarachnoid hemorrhages. Your blood vessels squeeze. Guess what? You basically stroke out again. You get ischemic infarct. And so that's not good. So we can prevent this by giving the patient nimodipine. This is a calcium channel blocker. Remember, this relaxes vessels. So you relax vessels, prevent vasospasm, and you do not get an ischemic infarct. Alright, this is a little summary slide of everything that we've talked about. It's not really adding much, but it does consolidate our information a little bit. So I just added it here. Okay, that's it for this section of strokes. We're going to continue with more information about strokes, especially the effects at specific locations of the brain.